Assalamu alaikum wa rahmatullahi wa barakatuh. Who is our dear colleague which will take this case, the first case? Dr. Abdullah, did you ask me on the okay, on the WhatsApp? Okay. Dr. Abdullah, I will unmute you. You are now unmuted. So, so as to save the time, I will start sharing the case now.
Okay.
So this is a station 5 case. Mrs. Kelly, sorry. She is a 41-year-old lady, came with diminution of vision. Please see and examine.
Okay.
Okay. When you are ready, Dr. Abdullah, just tell me.
Okay, of course. Okay, Dr. Khalid, we may start now.
Okay. Just I will make the timer for you.
Thank you.
Yes, go on.
Hello, I'm Dr. Abdullah, one of the doctors here in the medical admission unit. May I confirm your name and age, please? Is this
Yes.
Mrs. Kelly?
Yes.
And 41-year-old?
Yes, doctor.
Hello, hi, Mrs. Kelly. I got a letter from your GP that you are complaining of some problems with your vision. Is that correct?
Yes, doctor.
Would you please tell me more about this, Ms. Kelly?
Yes, doctor. For the last 3 months, I'm having diminution in my vision. I cannot see things well as before.
Oh, I'm sorry for that, Mrs. Kelly. And is that started suddenly or it was gradually in the beginning?
No, it was not. It didn't start suddenly, doctor. It was at the beginning. I can see things over 50 meters or 40 meters. Now I can see things over 3 or 4 meters only.
Oh, sorry for that, Miss Kelly.
Thank you.
Miss Kelly, and is this all the time or just a temporary thing?
It's all there. No, it's all the time, doctor. It's not temporary.
All the time. Any pain? I mean, any pain in your eyes?
No pain, doctor. No pain.
Any headache, Mrs. Kelly?
Headache?
Yeah.
Sometimes, yes, I feel headache. Sometimes.
Okay, and this problem with your vision, it's mainly on the daytime or more in the night?
No specific time, doctor.
Any problem seeing colors?
Problem in colors? No, doctor. No problem in color.
Any family history of similar conditions, Ms. Kelly?
No, doctor. All my family. I don't know my family. I am adopted.
Oh, and Mrs. Kelly, the main problem with the vision is in the center of your vision or at the sides more?
Mainly at the sides of my vision, doctor.
Okay, fine. And do you see any double visions, or it's only a single photo you can see?
No, I don't see things double.
Okay, and is that in your both eyes or only one eye?
Both eyes, doctor.
Both eyes. And Mrs. Katie, regarding this headache, could you please tell me more about this headache? Is that in the morning more or all the day?
Yes, doctor. More in the morning.
Okay, and is it increasing and lying forward?
Leaning forward, you mean?
Yeah.
Yes, doctor. When leaning forward, it increases.
Any sickness or throwing up, any nausea?
Nausea? No, doctor. Sometimes, but not usual.
Okay, and did you notice any weakness or any abnormal sensation in your body, your arms, your legs?
No, I don't feel like this.
Any problem with speaking before?
No.
Okay. So, Mrs. Katie, do you have any, I mean, any, could you please tell me more about any medication list you have?
Medications?
Yeah.
I don't use any medications. Occasionally paracetamol. Otherwise, I don't use any medications at all.
Okay. And did you notice any increase in the size of your hands or legs?
No, doctor, I didn't notice like this.
And the size of your shoes and ring? Nothing.
No.
Okay. Can I examine you, Mrs. Kitty, please?
Sure, doctor. What do you want to examine?
So the eye movements in all the directions.
All the directions of the movement are okay, doctor.
Pupillary reflex.
No problem in the pupillary reflex.
Visual field.
Visual field. Visual field is okay.
Okay. And I would like to do a fundus examination.
Sorry?
Fundus.
Fundus? Sure, doctor. I will share it to you now. It's on the board, doctor. You can have a look.
Okay. Okay, thank you. And Mrs. Kelly, can I ask you some more questions, please? Do you have any weighted change?
Weighted change? No, doctor, I don't have any weighted change.
Okay. Mrs. Kelly, are you married or have a partner?
No, doctor, I'm divorced for the last 2 years.
Okay. And are you using any contraceptives, any pills?
No, I'm not sexually active, doctor. 1 minute remaining.
Okay. So, Mrs. Kitty, can I know your main concern, please?
Yes, doctor, I'm very afraid. I'm very afraid I may lose my vision. I cannot see well now. Things are getting worse.
Sure, Mr. Bey, I highly appreciate your concern, and I think we need to include a team of doctors, eye doctors, and brain doctors as well, and doing some blood tests and scans. And at the moment, are you driving, Mrs. Kitty?
No, doctor, I don't drive. I have my private driver.
Okay, sure. So as I said before, we will refer you to a team of doctors, but most probably you have a vision, you have a problem with your nerve cable supplying responsible for the vision, and from the examination of your eye, I can see some problems with nerve cables could be related. Yeah.
Okay. What's your differential diagnosis, Dr. Abdullah?
So my differential diagnosis, papilledema, mainly increased intracranial pressure, could be idiopathic intracranial pressure, increase in intracranial pressure, or a space combined lesion, but there is no obvious neurological deficit. A space combined lesion, or yeah, it could be optic neuritis as well, but there is no pain, a painless optic neuritis.
Optic neuritis, okay. What about her past history? She is having past history of chronic diseases?
I didn't ask.
Okay. Okay, doctor. So what else do you know for the cause of increased intracranial pressure?
So it could be a tumors, or a primary tumors, or a pituitary adenoma. Could be drug induced, like
what types of pituitary adenoma do you know? Or the tumors in the pituitary generally?
So it could be prolactinoma, and it could be a pituitary adenoma causing acromegaly as well, craniopharyngioma.
Did you ask her about manifestations of prolactinoma?
No, I missed the prolactinoma.
Okay. So what's her concern, doctor? What was her concern?
So the main concern is losing her vision totally.
So did you answer her concern?
I think I told her that we will refer here, but we need to do more investigations and scans.
Thank you.
Yeah.
Thank you, Dr. Abdullah.
Thank you.
Okay. So thank you, Dr. Abdullah. You did well in the case, but let's add some things to make things easier, inshallah.
Sure. Thank you.
We can just we'll just open. Okay. So doctors, I will write on the I will write what are the pitfalls happened in this case. Number one, you cannot leave a person or a patient leave your room, or you leave him without asking him about the past history. Okay? Yesterday, we had a session, yes, and I said, doctors, please, in station 5, ask very early, very early about the medication list. Please make it your second or third question. Are you using any medications? Then she will tell you no. Here you good. You asked about the medication. She told you I'm using only paracetamol. Okay. But did you ask here about any previous, any past history of chronic diseases, of blood transfusion? They will not forgive you if you forget the drug history, if you forget the past history. Okay. So you asked about the family history, but you forget the past history. Okay. So please don't forget the CRB fast, okay? For sure, in station 5, you will not go in deep details, but at least you should ask about, do you have any past history of blood transfusion? No. Hospital admission? No. Chronic diseases? No. Very rapidly, very rapidly. Then do you have family history of the similar problem? No. Do you have any allergy? No. And then do you have any, what about smoking? You didn't ask her about smoking, by the way, and you didn't ask her about alcohol. This is very important. You should ask it to any person. If you found any person in your life, ask him, are you a smoker? Are you drink? Sorry, do you smoke? Do you drink alcohol or no? If any patient, even in the exam, you should ask him, do you smoke? Do you drink alcohol or no? Okay. Other things like hobbies and pets may work only in specific cases, like patients came with shortness of breath. You can ask him about pets for possibility of extrinsic allergic alveolitis, for example. So you should also go through that CRB fast, but very rapidly, not like what we do. This is one thing. The other thing, you start, this is a station 5, you started the examination very late. You should start the examination while you are talking. You should start the history in station 5 should take only 2 minutes. And during the remaining 5 minutes, yes, ask about history and examine the patient at the same time, okay? Because you know, you should also examine other things in this patient. You should not also examine his eye. If you examine the eye of the patient without offering to examine the cranial nerves, he will not forgive you. Patient came with eye problem, you should examine the cranial nerves, or at least you should offer them, okay? The other thing, when I told you I had a headache, you bypassed the headache. You just asked only one question. Does it increase with leaning forward or no? I said yes. Then you didn't complete. Doctor, headache is a pain. You should use the Socrates. Okay? But very rapidly, as we said, site onset course, character, radiation, association, timing, exacerbating or relieving factors, and the severity. So you have a headache, sorry for this. Can you please tell me more about this headache? When did it start? Does it take a special character? Okay, so did you notice that anything increase it or decrease it? Like it increase when you lie, when you lean forward or sneezing? Then go and how severe is it? If you give a score from 0 to 10, while 0 is the lowest possible pain and 10 is the highest possible pain, how will you score your pain? 3, doctor, 3 out of 4. Now the examiner will know that you know everything. Okay. Then come to the things. This patient, you discover that she is having bitemporal hemianopia. She told you sometimes I have a problem in the side vision, sometimes, not all the time. So if a patient came with a problem in his side vision, so I'll ask about craniopharyngioma or pituitary problem. I mean pituitary tumor. Pituitary tumor, we as PACES candidates always directed to acromegaly, and we forget the prolactinoma. Did you ask here about pregnancy, doctor? Did you ask here about nipple discharge? You didn't ask here about this. These are very important. And we said before, any female, you should ask here about 3 B's. Period, you didn't ask about it. Pills, you ask it. Pregnancy, you ask it. So if you ask it about the period, she will tell you, doctor, I'm having disturbance in my period. Oh, I'm so sorry for this. Do you have any nipple discharge? No. And if she told you that she is married or she is sexually active, you should ask here, do you the desire for the intercourse with you is okay or decreased? She will tell you, no, doctor, it's decreased. So you have, if you are thinking that your patient is having bitemporal hemianopia, don't be localized to acromegaly only. search for the prolactinoma as well. Okay, so now, doctors, we will take the approach of patients came with blurring of vision or diminution of vision or even loss of vision. It can work for all the patients that will present to you in station 5 in this way. So what are the causes of, before going to blurring of vision? As we said, when analyzing any symptom, onset, course, duration, what increase, what decrease, associations, effect of treatment, and the date of last attack. This is very important to analyze any symptom, any non-painful symptom. Okay. Then, if you found an eye case, you should ask the patient, do you wear contact lenses or no? This is very important because contact lenses can cause keratitis for some patients, and the keratitis can cause painful diminution of vision. Okay, so these are two important things to start with. Also, course duration, contact lenses. Your third question should be, what is the third question here, doctor? What is the third question in station 5? Dr. Abdullah or any doctor can answer. What is the third question in station 5? You will ask. Any doctor can write on the chat box if you would like. Drugs, excellent. Third question in station 5, drugs, drug history. Ask very early in station 5. Yes. Yesterday we said drugs for us as a physician means 3 things: medications, illicit drugs, and herbal medicine. You should not forget them. Then come how to approach a patient with blurring of vision. The first thing you will ask him, did it come suddenly? And you started very well, Dr. Abdullah, in this. You said, did it start suddenly or gradually? Because the differential diagnosis is different completely, except in 1 or 2 diseases. So if it started with him gradually, suddenly, then you have to ask another question. You shouldn't stop here. If you told you it started with me suddenly, ask another question. It lasted for how long? I mean, it's temporary or persistent. This is very important because the differential diagnosis is also different. So I will tell you, yes, doctor, it came all of a sudden. Oh, I'm sorry for this. So is it temporary? It happened temporarily with you? Or it is still persistent? What is the difference between them, doctor? He will ask you, what do you mean by temporary? I don't understand. So tell him, is it less than 24 hours or more than 24 hours? The differential diagnosis is different in between them. Okay? So the temporary causes of sudden loss of vision or sudden blurring of vision or sudden diminution of vision, you know the word fog, yes? There is another word like it's called mist, M-I-S-T, mist equal fog. So we will use the mnemonic mist, M-I-S-T. This is the cause of blurring of vision which comes suddenly and temporary. So what are these causes? What are these M? The first M for migraine. Second M for multiple sclerosis. Third M for methanol. Okay? If you are in UK, you will not face the cases of methanol, but if your exam in Egypt or India or any other places, you can say methanol. Why, doctor? Because you know, in UK and these places, ethanol is available. Ethanol, which is alcohol, is available. But in our countries, alhamdulillah, it's not available. Okay, so the people uses methanol, which is more cheaper than alcohol for them. And if you attended the course with Dr. Majdi or Dr. Ramadan, you will find the case there, Optic atrophy, all of a sudden secondary to methanol. There is one case there like this. So first M for migraine, multiple sclerosis, methanol. I for intermittent closed angle glaucoma. This is the second cause, intermittent. Third is sugar, whether hyperglycemia or hypoglycemia. For sure, hypoglycemia can lead to blurring of vision, which will be sudden and temporary. But hyperglycemia usually will not lead to sudden loss of vision, except if a complication happened very rapidly, like if he is having new revascularization and bleeding happened from this. So at this time, he can have sudden loss of vision. Then T for trauma, for sure. T for temporal arthritis. And T for TIA. So missed are the causes of sudden temporary loss of vision less than 24 hours. So TIA, here you should ask about the 6 questions of thrombosis. What are the 6 questions of thrombosis, doctors? What are them? Any doctor can mute him or herself. I will, and then he can say what are the causes. What are the 6 questions of TIA or stroke? Family history. Okay.
Any previous history of clots?
Yes.
Any mouth sores or private area sores?
Okay, basic disease, yes.
Any change in urine color at the morning?
Yes, PNH.
Any risk factors, smoking, any heart problems before?
Okay.
Any recreational drugs?
Okay. Polycythemia rubra.
Any joints? Yeah.
Okay. Polycythemia
Any
rubra
joints
also.
or rash?
Excellent. So any past history of clot, any family history of clot? Are you using OCBs? Are you a smoker? Do you have any problem in your heart before, like prosthetic valve or atrial fibrillation? Okay. Then ABP, antiphospholipid syndrome, joint pain, rash, recurrent abortion. Then B for basic disease, mouth sores in private areas. Then B for PNH, any change in the color of your urine at early morning or no? And the other B for polycythemia rubra vera. Did you notice that? Do you have any hypertension, any high blood pressure? Did you suffer any itching which increased after hot bath? This is a polycythemia rubra vera. Okay. Then, so we said missed are the causes of sudden transient loss of vision. Plus, for sure, hysterical. Patient came telling you that I'm having acute loss of vision and found finally that he is hysterical. Okay? So we finished these cases. I will just only add one thing here for the temporary. Why I did not put it with them? Because all these cases causes by binocular affection. It does not affect only one eye. If you found painless, monoocular, sorry, yes, painless, monoocular, I mean in one eye, loss of vision, so you are talking about amaurosis, fugax, thrombus, and then revascularized again, okay? So if it is in one eye only, which was transient, so this is an amaurosis fugax. Then come to the causes of persistent loss of vision. Sudden persistent, I mean more than one day. So the mnemonic RST, you know the RSTUVWX, okay? This is R retinal detachment. Number 2, stroke, for sure, patient had a stroke, okay? And here stroke, you have to, it may be ischemic stroke, 6 questions, or hemorrhagic stroke, 4 questions. And beside stroke, for sure, you will add central retinal artery, occlusion or central retinal vein occlusion. This, I think that this will not come in the exam, central retinal artery or central retinal vein occlusion. Okay. Then T for trauma, for sure. Trauma can cause temporary and can cause persistent. And the other T for thrombus. Also, we said thrombus already. No need to repeat it. We can add it here. So RST, these are the causes of persistent loss of vision more than 24 hours. So this is easy now. Do you have any blurring of vision? It started suddenly or gradually suddenly. It's temporary. I mean, it's lasted with you for less than 24 hours or more than 24 hours. Then you can get the diagnosis from here. Then come to the other part here, which is the gradual loss of vision. Gradual loss of vision, we are having two big entities. Two big entities. The first is, please, doctor, try to memorize this phrase. Colored night, peripheral family. Colored night, peripheral family. Colored night, very common, very common. Colored night, okay, peripheral family. So, do you have any color change? Yes, doctor. Do you have any problem in the night vision? I mean, or even you prefer, sorry, yes, you have problem in night vision? Yes, doctor. Did you notice that the peripheral part of your visual field is affected? Yes, doctor. Do you have any family history of similar problem? Yes or no? So if these four are present, so this is very common, retinitis pigmentosa. Retinitis pigmentosa. By the way, doctor, retinitis pigmentosa usually, because this will be a concern for one patient. He will tell you you diagnose him as retinitis pigmentosa, and then he will tell you that, doctor, I'm afraid to lose my eye. Then your answer should be, usually retinitis pigmentosa does not lead to complete loss of vision. I mean, does not lead to complete blindness, except if optic atrophy happens. Okay, it's an untreatable condition, by the way. You cannot treat the retinitis pigmentosa, but usually it doesn't lead to complete blindness except if optic atrophy happens. Then, if you get your case retinitis pigmentosa, no need. He will not ask you in details about the causes, the syndromes which are associated with retinitis pigmentosa, but the two important syndrome that you should know about retinitis pigmentosa is the Osher syndrome and Alport syndrome. Because Osher syndrome, this is the most common cause of congenital mute deaf person in UK. So if a congenital mute, he cannot talk, and deaf person in UK and is having retinitis pigmentosa, so this is an Osher syndrome. So mute and deaf. If you add it to mute and deaf kidney problem, so you are talking about Alport syndrome. So Alport is eye, ear, and sorry. Without, if you remove the mute and put kidney instead of it, so you are talking about Alport syndrome. So Osher syndrome is mute deaf, but Alport syndrome is deaf having kidney problem, and both are having eye problem. Others like Lawrence-Monbedel, hyperproteinemia, having diarrhea, Kearns-Sayre syndrome, Friedreich ataxia having, for example, weakness, and peripheral neuropathy. Peripheral neuropathy is not present in some disease, but the most important to know Osher syndrome and Alport syndrome. The next, so the first phrase, if he told you this is a gradual loss of vision, remember this phrase: colored night, peripheral vision. Peripheral family. Colored night, peripheral family. Then, if it is not present, then go to the next step, which as Dr. Abdullah did exactly. Do you have any headache? If you didn't ask about headache in station 5, even if there is sudden loss of vision, okay, you will fail. You will fail because he will mark you as an unsafe doctor. How can you? How it comes that you saw a case of blurring of vision and you didn't ask him about headache? Very dangerous. Okay. So do you have any headache? Then yes or no. What are the causes of headache, doctor? Of headaches with blurring of vision? What are the causes? We took it before. Yes, colored night peripheral family. These are the manifestations, doctor. These are the manifestations of retinitis pigmentosa. The eye manifestation of retinitis pigmentosa are colored, problem in the color, I mean colored vision, problem in night vision, problem in peripheral field, I mean tunnel vision, and family history positive. Okay, so headache, GCA, giant cell arthritis, but this is gradual, doctor. We are in the gradual now. We are in the gradual. We are not in the acute. Migraine, yes, migraine can cause both gradual and this. Okay, space occupying lesion, blah blah blah, tumor. Okay, doctor. We took it before, and there is a simple mnemonic for this. And as we try to learn with each other, we will try to take the mnemonic from the disease itself. So, patient with headache. So then, if you found him with headache, you should ask him about the criteria of increased intracranial pressure headache, which are LMN. LMN. So we took here RST, and then we took here LMN. L, leaning forward, headache increase with leaning forward. Morning headache. Nausea, associated with nausea, does it increase with sneezing? So if it is positive, you are talking about increased intracranial pressure. Yes, doctors? What is the mnemonic of increased intracranial pressure, or what are the diseases that causes increased intracranial pressure? You wrote some of them. But we can, so as not forget, we will derive it from the IICP, increased intracranial pressure itself, where the first I for infections. Patient with meningitis or encephalitis can have increased intracranial pressure, but usually this will not lead to gradual loss of vision. But that just I am mentioning it in the causes that increased intracranial pressure. Okay, the next I for idiopathic intracranial hypertension, pregnancy, steroids, tretinoin, tetracycline. Okay, obesity. Then C for clotting, and the clotting, sinus, thrombosis. Then B, two B's, pituitary and pituitary doctors, acromegaly and prolactinoma. Please don't forget prolactinoma. And if you attended the clinical course with Dr. Ramadan or Dr. Majdi, you'll find it. Okay, then the other B for, sorry, bleeding. Okay, so these are the causes of increased intracranial pressure, doctor. Infection, idiopathic intracranial hypertension, clotting, then pituitary and bleeding. And for sure, if you find bleeding, you should ask about trauma. No case will come to you with a blurring of vision and you will not ask him about trauma. Because trauma, if the patient is having intracranial hemorrhage, it will lead to increased intracranial pressure secondary to the trauma. For example, if he had trauma 3 days ago or 1 week ago, and then it's accumulating. Then now he came with increased intracranial pressure. You should ask about trauma. Okay. If there is no headache, so okay, look at the above, please. Look at the above. I will change the color. So, doctor, inshallah, in the next courses, I will make them as PDF and PowerPoint to be easy. Okay, so if there is no headache, so sorry, I couldn't find mnemonic for this, or I couldn't make a mnemonic for this. So متجلد. Okay. M for migraine. T for thyroid eye disease, Graves. Don't forget it. Okay, it can cause blurring of vision as well. G, very important to ask him about job. People who are working in batteries, lead poisoning, carbon monoxide poisoning. L, local eye problem. What are the local eye problems that can cause loss of vision? Cataract. Bring it from outside to inside. Lens, cataract. Macula, age-related macular degeneration. Intraocular pressure increased, glaucoma. So bring it from out to inside. Cataract, age-related macular degeneration, and increased intraocular pressure, glaucoma. Okay? The last D, sorry, you have to write because no space. So the last Ds are for diabetes and hypertension for sure. And the D for drugs. And as we said, drugs include what? For us as a physician, three things: medications, illicit drugs, and herbal medicine. Medications, what are the medications that can cause loss of vision? Gradual. Steroids, because steroids also can cause cataract. INH, ethambutol, digoxin. Digoxin leads to yellow vision, by the way. Digoxin leads to yellow vision. Viagra, sildenafil. This is a blue tablet or the blue capsule, leads to blue vision. So the yellow vision happens with digoxin, and the blue vision happens with Viagra. Okay? So now again, to wrap the things here. Patient came with blurring of vision. Can you, after analyzing onset, course duration, blah, 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 do you have any contact lenses? And even you want to ask, do you have any, are you using any medications? Any illicit drugs? Any herbal medicine? No. Then ask him, sir, did it ask sudden or gradual? Or even you can bring it from here, huh? For sure he will tell you from the beginning. Okay, so from the O, from the onset, you can pick everything here. Yes, doctor, it's gradual for the last 3 months. Then ask him about colored night peripheral family. Do you have any problem in your current vision? No. Night vision? No. Peripheral vision? No. Any family history of similar problem? No. Then come, do you have any headache? Yes, doctor. Oh, I'm so sorry for this. So can you please tell me more about this headache? So creates. So where is this headache? All over your head or only in a specific, around your eye, cluster headache, or like a band, tension headache, or half of your head? So you are thinking about migraine, you are trying to get that, no doctor, it's all over my head. Okay, I'm so sorry for this. Then when did it start? It started at the same time nearly, doctor, with this blurring of vision, or after it, or before it. Then, and you asked already about the character. Is it radiating to any place? No. Okay, time, does it have a specific time or come to you at a specific time every day? No, doctor. The headache that comes at a specific time of the day or a specific time of the year, every time, this is a cluster headache. If it is prolonged headache from 4 hours to 72 hours, you are talking about migraine. And we took the headache. The approach to headache, we took it already. Okay, so the timing. How it is severe? Is it, if from 0 to 10, how will you score it? Okay, then did you take any medication for this headache before, or the paracetamol, doctor? Okay, then add this LMNS. Does it increase with the leaning forward? No. Morning headache? Yes. Nausea? Yes. Sneezing? Yes. So you are asking, you are in the IICB. Okay, can I ask you please, sir, or please, Mrs. Kelly, are you pregnant? No, doctor. Are you using any OCBs? No, doctor. Are you obese or overweight? No, doctor. Are you using any medications? No. Okay, then come to the clothing. Ask about sex clothing. And then you came here at this point. Did you notice any change in the size of your hat, your ring, your shoes? No. And even you told her from the beginning that she is having problem in her peripheral vision. So you are talking about pituitary, either acro or prolactinoma. Don't forget prolactinoma, doctors, please. Please don't forget prolactinoma. Okay, so this is the approach of patients with blurring of vision. Some things I need to add in the eye cases, because I know that eye cases are unpleasant for all of us. But the patient came with painful loss of vision. Painful loss of vision. Ask him, how can you describe this pain? If this pain is sharp and only superficial in his eyes, what is the most superficial part of our eyes? Cornea. So this is a keratitis. You doctor, if your eyes dry, this is a pain of keratitis. When you make rubbing your eyes with your hand, this is a keratitis. So it's a superficial and sharp. Okay. Or do you feel it? An deep eyebrow ache. It come in the eyebrow. Deep eyebrow ache. So associated with nausea and vomiting sometimes. So you are talking about acute angle glaucoma. Third one, this pain increases with eye movement. So you are talking about optic neuritis. Sorry, doctors. There is Dr. Samia. I muted you because there are noise in the background. So this is optic neuritis. Okay. Okay. Now we talked about the causes of blurring of vision. What are the causes of diplopia? What are the causes of diplopia? The causes of diplopia or double vision nearly the same of the causes of blurring of vision, apart from little things that we will add. Don't forget myasthenia gravis. Don't forget multiple sclerosis. Don't forget PSP, progressive supranuclear palsy. Okay. Diplopia doctors there are nearly 30 or 40 causes of diplopia. Most of them are the causes of blurring of vision, like multiple sclerosis, like hypoglycemia, like hysterical, like trauma. Lots of cases, lots of causes can cause it, diplopia. Okay, stroke, for example, if the patient has third or sixth cranial nerve affection. Okay, intracranial pressure, by the way, can cause diplopia. What is the mechanism? Increased intracranial pressure will compress the sixth cranial nerve and then leading to diplopia. So the causes of diplopia or double vision can be applied to the blurring of vision. But please don't forget myasthenia gravis, don't forget multiple sclerosis, and don't forget progressive supranuclear palsy leads to vertical diplopia. Vertical diplopia. Okay, those patients with PSP suffering when they go upstairs or go downstairs, they are having the vertical diplopia. What is the difference between, next part of this session, what is the difference between bitemporal hemanopia and the tunnel vision? The bitemporal hemanopia, doctors, if this is, see, I will tell you first, if this is the eye, this part is called the peripheral visual field. And this part is called the central visual field. If this part is, if this part is affected, I mean the peripheral part, if this part is affected, so this is called the peripheral visual field loss, the whole circle. Okay, so it will lead to tunnel vision for sure. So it will lead to tunnel vision. But if this is the eye, let me draw with this. If this is the eye, okay, and the affection is in the sides, so this is hemianopia. Hemianopia. Okay, clear now? Because you will ask your patient, what is your problem in your eye? Dr. Abdullah, mashallah, asked, do you have problem in the sides of your vision? If he said no, okay, do you have peripheral visual loss, or your vision looks like as if you are looking through a tunnel. So there is difference. Causes of hemanopia, as we know, it's a pituitary adenoma or craniopharyngioma. Causes of tunnel vision. He will tell you, not the doctor. It's as if I'm looking through a tunnel. If you are looking through a tunnel, so the causes are glaucoma, retinitis pigmentosa, or I will tell you something easier, glaucoma, retinitis pigmentosa. No, I will tell you something easier. Causes of optic atrophy. The pale disc, a very common mnemonic, optic atrophy. This causes tunnel vision. Not all causes of optic atrophy, but we will say which causes of optic atrophy that cause tunnel vision. Okay. So the causes of optic atrophy, it's called pale disc. Why pale disc, doctors? Before going to optic atrophy, I will tell you something because it is irritating to all of us. What is the difference between optic atrophy, papilledema, post-papilledemic optic atrophy, post-papilledemic optic atrophy, and the normal eye? I'll tell you an easy way, inshallah, to know it. When you look at the optic disc, you will find it one of the two things, yellow or white. White means pale. Okay. So if you found the optic, if you look at the optic disc, you'll find it yellow or white. Yellow is the sun. White is a moon. Okay. Sun is yellow, moon is white. Easy. Then, if it is well-defined sun, like this is normal. By the way, doctor, they brought a case before headache, and the case, and during, for sure, patient with headache, you should examine his eye. Patient with eye, see doctor. Patient with headache, examine his eye. Patient with eye problem, ask about headache. You cannot separate any of them. And they brought the case, and the case was migraine, and they dilated his eye, by the way, okay, by this drop, and the eye was normal. And the exam, and so the candidate told them, I didn't find any abnormal. And then in the mark sheet they wrote that he correctly identified no signs in the eye. Okay. So don't always expect to find the pathology. So well-defined the sun, this is normal. Ill-defined, so it means that there is fluid. Ill-defined, so there is fluid. So ill-defined the sun, I mean ill-defined something yellow, but ill-defined, I mean the borders are not well demarcated. So you are talking about papilledema. So you can say about papilledema, if you would like to say irregular sun, or well demarcated sun, or ill-defined sun, irregular sun, like this. You may not see the borders at all in the papilledema because this is a fluid, and the fluid will remove the borders. Come to the other part, white. White equal pale. White equal pale equal optic atrophy, or yes, optic atrophy. If you found the white moon, if you find it well-defined moon, so you are talking about optic atrophy. If you found an ill-defined moon, so moon, optic atrophy. Ill-defined means fluid. So post-papilledemic, because papilledema here, sorry, papilledema, we said it's a fluid, makes things irregular. Ill-defined, it means that there is papilledema. And the moon, optic atrophy. So this is a post-papilledemic optic atrophy. Easy? I hope it will be easy now. I will show you the difference between them now. I will share both of them to know the things. You know, doctor, sun is sun, yellow color. This is the normal optic disc. You'll find it yellow. Okay. So, what do you think about this one, doctor? This is a sun or a moon? Does it look like white? Doctors, you can write on the chat box. Does it try white or yellow? This optic disc. Sun, excellent. Is the borders well defined or ill-defined? Ill-defined, excellent. So this is an ill-defined sun. So this is papilledema. Ill-defined sun. Ill-defined sun. Because in the well-defined, you will find the marks as if you wrote it to draw it with your pen. You know, it will be very well defined. So this is an ill-defined sun. So you are talking about papilledema. So the only abnormal here is the papilledema. By the way, also, doctor, there is silver wiring here. Okay. Which one is the artery and which one is the vein? The dark one, mostly the vein. The dark one, because it contains deoxygenated blood. And the smaller one is the artery. So these are the artery, and the wider one are the veins. Okay, so I will show you another one. Oops, sharing stopped. I'm sorry. Okay. What do you think about these doctors? Is it a sun or a moon? Moon. Well-defined or ill-defined? Moon. Look at the borders, doctor. Very clear, as if you, yes, well-defined. So this is an optic atrophy. Very easy. So well-defined moon, this is an optic atrophy. So the first thing, when you look at the optic disc, look at the color. If the color is white, so this is an optic atrophy. If the color is yellow, it may be normal or papilledema. Look at the borders. If it is irregular, so this is a papilledema. But if you found an optic atrophy with irregular borders, or even you cannot see the borders, so you are talking about post-papilledemic optic atrophy. Okay. Sometimes in cases, and there is also one case in Egypt in the clinical course, you will see it. Patient with papilledema in one eye, I mean sun, ill-defined sun in one eye, and optic and the moon in the other eye, optic atrophy. So patient having optic atrophy in one eye and the other eye is having papilledema. Okay, this syndrome, you know it, patient having papilledema in one eye and the other eye having this optic atrophy. What? Yes, Foster-Kennedy syndrome for sure. It's a tumor in the frontal lobe causing papilledema in one eye and optic atrophy. Optic atrophy because it's causing pressure, and papilledema for sure because there is revascularization around the tumor. Foster-Kennedy syndrome. Okay, if you found sun plus moon, I mean sun in one eye, moon in other eye, so you are talking about Foster-Kennedy syndrome. Okay, doctor, till now everything is okay. So how to diagnose optic atrophy? Inshallah, it will be easy now. I want you to have a look again to optic atrophy on the internet now. It will be after finishing the session. So come to the causes of optic atrophy. We said optic atrophy, it's like a moon and it's pale. So the mnemonic for this is pale disc. Pale disc. B for pressure, increased intracranial pressure. Okay, and the cause of increased intraocular pressure intraocular pressure, like glaucoma, for example. Number 2, ataxia. Friedreich ataxia leads to optic atrophy. Leber's optic atrophy. D for degenerative, which is the retinitis pigmentosa. We said normally usually retinitis pigmentosa does not lead to complete loss of vision except if optic atrophy develop. Okay. Also, vitamin B12 can lead to pale optic disc. I for ischemia. Any vasculitis in the eye can lead to ischemia, especially temporal arteritis. And then S for sclerosis, multiple sclerosis. And C for cyanide poisoning and methanol. And I told you, if you are in UK, no need to mention methanol, or just tell him methanol, but it's very rare, because you know alcohol is present there. But in our countries, alhamdulillah, we don't have this alcohol except very rare. So people use, unfortunately, the methanol, which causes optic atrophy, irreversible optic atrophy. Okay. Alcohol can cause, yes, or can cause blurring of vision. Sorry, the ethanol, which is the regular alcohol, but it can cause acute or gradual. But methanol leads to alcohol leads to gradual. The ethanol. Methanol can cause acute or gradual, and unfortunately, it's irreversible. Okay. Then, still we are having two items: multiple sclerosis and the eye. What are the effects of multiple sclerosis of the eye? Doctors, you can write on the chat box if you would like. What are the effects of multiple sclerosis on the eye? Any doctor can share with us what is the effect of ophthalmoplegia? Okay. Talking about the eye, yes, ophthalmoplegia, optic neuritis, retrobulbar optic neuritis. Okay. What else? Red desaturation, papilledema. Papilledema, I don't know if it is causing papilledema or no. I have no idea if it's causing papilledema or no. I don't know. Okay, so if the examiner asked you, yes, Arthur's phenomenon, yes, Arthur's phenomenon, the eye affection increases with the hot weather. So the effect of multiple sclerosis on the eye. A, for visual acuity, it decreases the visual acuity and it can lead to optic atrophy. B, blurring of vision and eye pain. C, scotoma, blind spot, scotoma equals blind spot. EBC. D, diplopia, secondary to ophthalmoplegia. And the other one, as the doctor said, O, optic neuritis. So ABCDO, these are the effect of multiple sclerosis on the eye. Last thing to talk about is the hemorrhages in the eye. The hemorrhages. The hemorrhage that happens in the eye, it may be, or the things that you will find in the retina. You will find dot hemorrhage, dot diabetes mellitus, happened with diabetes mellitus. Hard exudate happens with diabetes mellitus. Okay. This is a dot hemorrhage. Flame hemorrhage leads to hypertension. How to remember? You know, doctor, remember that flame, hypertension leads to sudden gush of blood, like flame. Okay. blot hemorrhage. Blot, huh? Happens with both hypertension and diabetes. So things with the hard exudate, dot hemorrhage happens with diabetes. Flame-shaped hemorrhage happens with hypertension. Blot hemorrhage happens with both disease. Last thing, sorry, I forgot to tell you that we will talk about the cataract. What are the causes of cataract, you know, doctors? Or how to diagnose the cataract. For example, you are in the exam and you found your patient is having a cataract. Sometimes we get confused between cataract and sometimes we can be confused between cataract and glaucoma. See, doctor, cataract. Cataract is cloudiness of the lens, cloudy lens. This is a cataract. Cataract, cloudiness of the lens, plus loss of red reflex. So the first thing when you are trying to put your ophthalmoscope inside the eye of the patient, you will find loss of red reflex and you will see cloudness. Then stop here. You cannot see what is the posterior part of the eye. You cannot see anything. Things are cloud. Tell the examiner I cannot see anything in this eye. It's cloud. Sorry, he's having cataract. So he will ask you, what are the causes of cataract? You know, doctor. What are the causes of cataracts, doctor? You know. Right, doctors. Or even if you want to talk, it's okay. Doctors who don't like to write, they can talk. If you want to unmute yourself, it's okay. Steroids, diabetes. What else? Congenital. Okay, what else? Post-traumatic age. Senile aging. Okay. Excellent. Senile. Drugs. Okay. We said we will try to make mnemonics from the disease itself so as not to forget anything. So what are the causes of cataract? C. Cushing. And for sure steroids or cortisone. Better to write cortisone. Okay. A for aging. T, an infection in the childhood called Torch infection in the childhood. Then another autosomal dominant, myotonia dystrophica. Okay. R, raised blood sugar, which is diabetes. A, anti-malarial medications, anti-malarials. C, chlorpromazine, antipsychotic drug. And last T for Turner syndrome, Down syndrome. Okay, and the other one, Fabry disease, Fabry. Okay, so again, these are the causes of cataract. Cataract, Cushing, cortisone, aging, Torch infection, autosomal dominant, myotonia dystrophica, raised blood sugar, diabetes, anti-malarials, chloroquine, cataract, sorry. And the last T for Turner and Down syndrome and Fabry. Okay, doctors, now we are at the end of our session. Do you have any question? Do you have any, do you want something to be explained? Thank you, doctor. Don't forget to examine the eye, to ask about headache, and to examine the cranial nerves in any case of headache or any case of eye problem. Please don't forget to ask about any weakness and to examine the power and the tool very rapidly if you have time. Okay, so in eye case, you will not only examine the eye doctor. In the eye case, you will examine the fundoscopy, the eye movement, the cranial nerves, and you can offer to examine other things like full neurological assessment or whatever. Okay, doctors, I didn't went deep to the diseases to the management of the diseases, because I think management of the disease is easy. You don't need to know more details. If you picked up the diagnosis, everything will be easy after this. But if you picked up a wrong diagnosis, everything will be hard. So the best way is to go to targeting directly to your case. Blurring of vision, onset, sudden, gradual. Sudden, temporarily than 24 hours, missed, more than 24 hours, RST. If it is gradual, so the first step, peripheral colored nights, peripheral family. Nothing from this. Do you have any headache? Yes or no? Yes. Increased intracranial pressure. And the mnemonic, IICP. If it is no, so ask about MTLG-LD. Migraine, thyroid diseases, I mean Graves' disease. Job, local, like cataract, age-related macular degeneration, glaucoma. Then nothing from this. Ask about diabetes, hypertension, or drugs. And drugs for us, as a physician, mean three things. Medications, illicit drugs, herbal medicine. Thank you very much, doctors. Happy to see you today. And if you have any question, just ask me. We are at the end of our session. Thank you. Yes, doctor, it was a prolactinoma case. Yes, it was a prolactinoma. Yes, we said the minute it was a prolactinoma. Okay, thank you very much, doctors. We will upload this session on the on the YouTube, inshallah. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.